coding and developing web solutions for the healthcare setting. I also have extensive experience making and developing medical registries, including the development of the first national Alzheimer's medical registry for Saudi Arabia. I'm also the co-founder and the CEO of Cogni.Dx, which is a London-based startup that provides early-stage diagnostic and long-term care solutions for neurological conditions. And the first condition that we are tackling is dementia. So Cogni.Dx was established and it exists to provide early access to dementia treatment. It enhances the patient's experience with their GP, and it helps GPs regain their confidence in diagnosing dementia. We will talk a bit more about Cogni.Dx towards the end of our seminar, but for now, it's enough about me. And let me take this time and introduce our next two speakers for today. So it's an honor and privilege to introduce to you Professor and Dr. Claudia Jacova, who is Cogni.Dx's clinical advisor from Portland, Oregon. Professor Jacova is a professor of clinical psychology at Pacific University, Oregon. Her interests have evolved from normal memory functioning with emphasis on prospective memory to declines in aging and neurodegenerative dementias. She has internationally recognized research expertise in characterizing early manifestations of Alzheimer's, frontotemporal dementia, and vascular dementia. She is one of the lead authors on the novel diagnostic framework for Alzheimer's disease, which was proposed by the International Working Group, also known as the Dubois criteria. She has also contributed conceptually to defining the diagnostic entities of prodromal and preclinical Alzheimer's disease. A very warm welcome to you, Claudia, and thank you for joining us today.
Good morning, everybody. Good morning, Bushra. Thank you
Claudia,
very much.
can you hear me?
Yes, I can. Oops, I can hear you.
Not sure if she can hear me, but
yes,
let me go on. Can everyone hear me
Bushra,
right now?
We can hear you, and we can hear and see Claudia as well. But we cannot see you at the moment, Bushra.
Oh, no. Shall we chat her?
Okay, she's back. Yeah, she's back.
All right.
Bushra, you're mute.
Yeah, I don't know why I went out. Let me just reshare everything. Can you see this and can you hear me?
Yes, we can hear you and we can see the slide.
Okay, did everybody catch my introduction about Claudia or no?
Yes, except for the fact you said it's Dubois criteria, it's Dubois-Jacova criteria.
It's okay.
Jacova,
it's okay.
It's criteria for both of them.
Okay, so she has also, in the end, she has also contributed conceptually to defining the diagnostic entities of prodromal and preclinical Alzheimer's disease. So a very warm welcome to you, Claudia, and thank you for joining us today.
Good morning to everybody.
My next is, thank you. Okay. So my next esteemed speaker for today is Dr. Najeeb Qadi. Dr. Qadi is the co-founder and clinical advisor for Cogni.Dx. He is a cognitive and behavioral neurologist with a subspecialty in dementia from University of British Columbia, Canada. He is also the director of the largest neuroscience center in the Middle East at the King Faisal Specialist Hospital, Riyadh, Saudi Arabia. Dr. Qadi is also an associate professor at Al Faisal University, Riyadh. He has extensive experience diagnosing and treating different forms of dementia, ADHD, and other forms of behavioral disorders. Thank you so much for joining us today, Najeeb.
Thank you very much. Thank you, everyone. Good afternoon.
Najeeb, are you there?
Good morning. I am, and I think you again.
I'm assuming everybody's having connection problems like me.
Well, I don't know. Are others able to hear me?
Yes, we're able to hear you
just fine.
Yeah. So, Bushra, it's basically you are not able to hear us or see us, but
Yeah, I think it's my internet connection that's really bad, but okay.
Right.
So the one common bond that has brought together each member of our team is our experience and dedication to changing lives for people with dementia. So let me just introduce to you what dementia is. So dementia is a disease that has no cure, no survivors, and you grieve the loss of your loved one while they are still alive. And this loved one can be my parent, your parent, and many other parents whose lives have been devastated with this disease. So by the time you hear this sentence, someone in the world will be newly diagnosed with dementia, because every 3 seconds, an additional life is irreversibly changed by a dementia diagnosis. There are more than 50 million people worldwide currently living with dementia, and this figure is forecasted to increase nearly 3-fold to 152 million by the year 2050. Dementia has taken over all the continents of the world, with the majority of sufferers in Asia. So it is undoubtedly a massive global pandemic. If global dementia were a country, it would be the 17th largest economy in the world, exceeding GDPs of both Saudi Arabia and Switzerland together. Now, with this quick introduction into the scale of the challenge that we are dealing with, I will now leave the stage for our first speaker, Dr. Najeeb Qadi, to tell you more about the clinical aspects of dementia. So over to you, Najeeb.
Thank you very much, Bushra. Thank you for the introduction. Thank you, everyone, for joining us. So, dementia, let's think about it. All of us have higher mental functions, and they are basically divided into cognitive and behavioral domain. Now, what does cognitive domain mean? It's comprised of 5 subdomains. One of them is memory, the other is language, executive function, visual spatial domain, and praxis. I'll just mention briefly what each and every domain means. However, the point is, when do we consider an individual having dementia? We all can have lapse in our judgment and decision-making, memory, language, or our skills. So we consider an individual having dementia when there is an impairment in their function. So if the impairment is in their instrumental activities of daily living, this is where, like, they're not able to do use the instruments they are using all the time, such as banking, cooking, doing complex kind of function, then we consider the individual as having dementia, whatever the subtype is. If the individual is not able to do basic activities of daily living, such as feeding, bathing, then that is considered as moderate dementia. And severe is when they are bedbound and totally dependent. Next slide, please. So let me take you into, Bushra, next slide. Please, can you hear me? Okay, perfect, thank you. So if we go into memory, to make it simple, we have 2 types of memory. We have the short-term memory and the long-term memory. Short-term memory is known as working memory, and this is the RAM of our computer. I know there are many computer geniuses in the audience at the moment. So this is your RAM. This is what you use when you are trying to focus, when you are receiving information and having a temporary storage. It is basically in the prefrontal cortex. That means in the frontal lobe. Frontal is the anterior area of the brain. Then this is the parietal area. This is the temporal area, and this is the occipital, which is the last aspect of our brain. So working memory lasts for a few seconds, around 40 seconds maximum, and thereafter it changes into something we call a long-term memory. Next slide, Bushra, if you're there. Okay, thank you. So long-term memory, it has been divided into 3 major parts. One is knowing how to do something, which is how to do a certain procedure which you are used to doing, like riding a bicycle. and that is known as procedural memory. And it comes mostly from the unconscious part, like when you are riding a bicycle and you're used to it, you don't think, okay, now I will pedal, now I'll do it. It just happens. That is procedural memory. While the other aspect is declarative memory, is knowing a certain thing. And it has been divided into two aspects: the episodic memory, which are your previous events, like the marriage, birthdays, what did you have for dinner last night, when is the last time you went on a vacation. Everything memory associated with an event is known as episodic memory. Semantic memory is more of fund of general knowledge and understanding meaning of words. And for people who want to know more, episodic memory is basically your hard drive, and this is in the medial temporal lobe, hippocampus, parahippocampus, and semantic memory is in the anterior and inferolateral temporal lobe, while procedural memory is divided between cerebellum, basal ganglia, and supplementary motor area. Next. So this is the long-term memory. We are done with the memory. We go into language. Now, we all understand language means how to speak. Well, that's not everything. Language has 6 components, and the 6 components are fluency, which is your spontaneous speech, ability to retrieve words fast with a certain letter or grouping them. When we ask, like, please give us 10 animals that walk on 4 limbs, and you will start remembering. So you will talk about, either you will remember the ferocious one, then the domesticated one, or the big and then the small one. So this is fluency. Then comes comprehension. Comprehension is understanding meaning of words or understanding the conversation itself. And repetition is, of course, we are repeating phrases or numbers, naming certain objects, and then reading and writing, whoever is literate. So these are the 6 components of language, and even sign language is a language per se, because it has these components, or most of them. Next, Bushra, please. So then we would be talking about executive function. What does executive function means? It is in the frontal lobe. This is like executing a task. So it's comprised, some consider it 8 domains, some consider it 6. So basically, it's pretty much the same. It is how you're able to plan a certain thing, how you're able to prioritize things, reflect on certain aspects, and have inhibitions regarding certain things, emotional aspects, especially flexibility, and how to able to change your ideas or change the way you think. Organizing and planning, they go together. And how to achieving goals. When you have goals and you're trying to achieving goals, you're basically using the executive function. And again, it is in the frontal area of the brain, frontal lobe. Then comes the visual spatial domain and praxis. Next, please. So if we talk, the visual spatial is basically gnosis, is the higher level of recognition, when you're able to recognize familiar faces, or able to recognize when you're copying certain things. And this is what we consider as gnosis, and impairment in that is considered agnosia. Like prosopagnosia is when a person is not able to recognize familiar faces. Praxis is previously learned task, be it motor or sensory. For instance, brushing our teeth, tying shoelace, unbuttoning a shirt, all the driving a car. This is all part of praxis. Not able to do that while there are no deficits in motor or sensory or coordination, this is considered apraxia. So these 5 domains are what comprise our cognition, and impairment enough to cause functional decline is considered dementia. Now, dementia is a big box. There are several different types of dementia. Next, please. And there are hundreds of different types of dementia. The next, if possible, Bushra. Okay, thank you. So several trials have been done, and they have found that Alzheimer's disease is considered the most common cause of dementia across lifespan. And you will appreciate that it's around 50%. Some considered 60, some 40, but it's around 50%. And the second most common is the vascular dementia. Mixed dementia is when a person has vascular dementia and also develops Alzheimer's disease, which I'll mention in a while. And this is quite common as well. If you're talking about young individuals, less than 65 years of age, frontotemporal dementia is the second most common cause of dementia. And in fact, if you go into the East Asia Pacific, you will appreciate that frontotemporal in some trials have been considered to be the most common cause of dementia. In elderly, the second most common cause of dementia is dementia with Lewy body, where Parkinson's features are associated. And this is quite important because when a person comes, it matters what type of dementia, because it depends on how you will manage them. And more importantly, you need to go into the early diagnosis. How can you diagnose early these type of dementia, and even something called prior to dementia or prodromal stage, which is called mild cognitive impairment, which Prof. Jacova will discuss thoroughly in her presentation. And now, once we came to know about the types of dementia, I would like to briefly talk about the treatment of dementia and thereafter the prevention of dementia. Next, please. So if we talk about treatment of dementia, next, please. Thank you. It has been found that individuals with dementia have loss of neurons in the brain, and especially in Alzheimer's disease being the most common and the most studied, it was found that they have a loss of cholinergic neurons, neurons which produce acetylcholine, and that is in the nucleus basalis of Marinette or basal forebrain. Now, to make it simple, for information to move, you need basically in normal conditions, you have the presynaptic, postsynaptic, and this is the synaptic junction where the acetylcholine is present. But in pathological conditions such as Alzheimer's disease, the acetylcholine is not there. Not enough is there because there are several different pathways which lead to hindrance of its presence. And this was the idea, next please, why not to give these individuals, dementia patients, especially the Alzheimer's disease, cholinesterase inhibitors, which increase the acetylcholine in the brain. And this has had a significant positive impact on patients, but it's only symptomatic benefit. Usually it helps between 12 months to 18 months. And we have different types. The first one was Tacrin, but because of hepatotoxicity, it was discontinued. And thereafter came donepezil, and then the rivastigmine, and then galantamine. They are all pretty much the same. They have known benefit and known risk factors. Now, the other modality which came into picture is memantine. And that's an uncompetitive antagonist to NMDA receptor. And what it means is, in simple terms, is our most excitatory neurotransmitter is glutamate. In Alzheimer's disease, unfortunately, it is secreted in abundance, and that causes a significant hindrance as it leads calcium, the second messenger, into a messenger of death and apoptosis, so the cells die. And this was the idea behind getting memantine, which has also shown benefit. Now, I would like to clarify certain aspect that the approval here is FDA approved, which is in states, and that's why, as well as North America, so in Canada. So cholinesterase inhibitors are beneficial in mild to moderate stage, while the memantine has been approved from moderate to severe stage. However, if you come to Europe, especially UK, you'll find that cholinesterase inhibitors are given more than mild. They are given more in moderate and severe, and memantine is considered more as research, and not everyone believes in the benefit it has. And this puts us under more stress that we don't have real treatment for this pandemic. While, and as it was shown that because of longevity and improvement in patient care, individuals will live longer and hence are more likely to have dementia. Next slide, please. So the pathological hallmark for Alzheimer's disease, which is the most common cause of dementia, has been amyloid plaques and neurofibrillary tangles. So you will appreciate any neuron in the brain, the neuron is normal, and if you look down the neuron, there are neurons with neurofibrillary tangles or with amyloid plaques. I'm not sure if you can see my cursor because I'm not the one who is showing the slide, so I believe there's no point in showing the cursor. So thank you very much. So if you talk about amyloid plaque, what is amyloid plaque? It's basically every cell has a base, every cell has a cell membrane, so there are base proteins. And as a part of normal physiology, the cells die, so the proteins are broken down into smaller polypeptides, and they are taken away from the body and the brain. Now, in pathological condition, we have certain enzymes which are known as secretase. In physiological condition, we have alpha and gamma secretase, while pathological condition, we have beta and gamma secretase. To make it simple, it produces a larger polypeptide, so it breaks down the protein, the cell membrane protein, into large polypeptide, which the brain is not able to get rid of. So they stick together and form beta-plated sheets, sticky material on the cells, and leads to cell death, and that's called the amyloid plaque. While the neurofibrillary tangles are basically, if you want to transport information from one part to another, you need microtubules. So from one cell to another, same like when you are transferring water, so you need pipes. So these pipes in the brain, in the cells, are known as microtubules. And the cement which joins all these microtubules is known as tau. Now, in pathology such as Alzheimer's disease, a phosphorus compound binds to tau, and the tau detaches from these microtubules. So the microtubules fall apart. It's like if a person has a necklace, or you have, suddenly something, the thread is cut or the chain is not there, you will feel the beads falling apart. And this is what happens to microtubules, so the cells die as there is no transfer of information and signaling. And these neurofibrillary tangles, which have, the tau, which has been phosphorylated, goes into clumps and forms neurofibrillary tangles. Why this is important, next slide, please. Over the last 1 decade, there has been or in the last 2 decades, there has been significant trials going on to develop disease-modifying agents. So if you would realize here, this was more than a decade ago, and you would appreciate that several trials are there for decreasing the amyloid beta production or aggregation and improving their clearance, or decreasing the tau phosphorylation and aggregation. However, you will appreciate the only ones which reached to phase 4 and which improved were basically the anticholinergics, and which is the donepezil, rivastigmine, galantamine, as well as the NMDA receptor antagonists. Until recently, next slide, please. Recently, a new medication came into picture. You all must have heard about it. It is an anti-amyloid beta monoclonal antibody, which is known as aducanumab. And it was 2 trials have emerged. One was called Engage and one was called Emerge. You will appreciate that if you look simply at the picture, you will appreciate that all the 3 colors are pretty much going through. The purple color is the high dose of aducanumab, and you will appreciate that in Emerge, basically the higher it's going, the worse the condition is being in the CDR boxes. This is the number where the less number means 1 means mild dementia, 2 means moderate, and 3 means severe dementia, and 0.5 means mild cognitive impairment. So you will appreciate that individuals who were taking high dose of aducanumab over 78 weeks, which is 1.5 years, did have some benefit in the CDR. However, the Engage trial did not show that benefit. And this is something important. If you look at the second slide, the next slide, please, it also shows that, next slide, please. Oh, this is the next slide. Sorry. Okay. Sorry. Go back. Thank you. So it is basically showing the amyloid PET. Amyloid PET, like PET scan, is positron emission tomography, which shows you the function of the brain, and it shows you here it is significant for amyloid. So it shows how much amyloid burden is there, and you will appreciate that there was benefit again in the Emerge trial. and not really much in engage. So it did show some benefit. Now, as you are aware that these trials are showing that there is some benefit. However, we are still in a gray zone. It's not clear if the benefit is significant enough to be used for patients. There are side effects, and at the moment, we have to take this information with a pinch of salt and be cautious about it. But it does make you feel that new medications, which further trials are ongoing, other monoclonal antibodies might come, which might be more beneficial. Up to now, 5 monoclonal antibodies have been studied. This was the most, to some extent, most impressive. Next slide, please. So now let us talk about the other aspect of my, if you go forward, please. Which is the how to prevent dementia. And this is where a lot of focus has happened. 780 trials are ongoing to demonstrate how to prevent dementia and to find the appropriate treatment. So this is an important slide, and I would like to here to take a pause. If you look at this, this is basically all the modifiable, either protective or risk factors of dementia throughout life, from infancy till the end of life. And if you see this is a class 1 evidence where it's clear that these are randomized trials or strong observational trials. So this meta-analysis was done on 153 randomized controlled trials and 258 observational trials. And there are level A evidence and level B evidence. Level A evidence is when you have a strong evidence that this thing is helpful. Level B is it is less strong, but there is evidence that it can be beneficial. 3 is more of, level C is more of expert opinion, and then level X is that it's harmful. And you will appreciate that during the schooling has shown to, so there are basically, these are 9 factors which they looked into. Even though the trial was, it came last year, but the inclusion for them was up to 2019, mid-2019. So the 19 factors, 10 of them were level A and 9 of them were level B. Level A, basically the schooling was a factor. One of the risk factors was depression. So the green color, if you focus on that, depression, stress, which leads to this, hyperhomocystinemia, which comes even more apparently with vitamin B12 deficiency. You can appreciate it. Head trauma, which is significant, repetitive head trauma. What happened to Muhammad Ali Kilay or Cases Kilay, and he had a dementia called dementia pugilistica due to repeated hit to his head, which is close to Parkinson's dementia. And how much cognitive activity is there? Of course, the blood pressure comes into the picture, the stroke, and the cardiac conditions. And if you will appreciate, even level B evidence has shown that physical exercise and healthy dietary patterns are beneficial. In fact, even vitamin C. Few things they missed, especially one of them was hearing loss, because next, please, the hearing loss, okay, I've started with the non-study. Let us just please take a pause on that. That hearing loss is very important, especially if it comes in the mid-life and early in life. So you will appreciate that. But the trial came just 2 months ago, so the meta-analysis was huge. But this trial was up to 2019 only, the one I showed you. So non-study. So nuns of Rotterdam, they were gracious enough. As you know, nuns are wonderful angelic individuals who live together, and they are away from most of the things that can be harmful in taking, like alcohol, smoking, and others in general. And they tend to live together, so they are pretty much, the external environments are pretty much the same for them. And it was appreciated, and this came a quarter century ago, and this trial is one of the most significant, that even if there are very small scarce strokes, the likelihood, so the strokes are there, so it's more of vascular dementia, and the likelihood of developing Alzheimer's disease increases by 20-fold, 20 times, which is 2,000%. So this is why I mentioned that mixed dementia is known to have a huge burden. Like people have repetitive strokes and then they develop vascular dementia, and they also the Alzheimer pathway is triggered, and then they develop mixed dementia. And this is why stroke prevention is the #1 thing we emphasize on to prevent development of dementia or Alzheimer's disease. Next, please. The blood pressure and dementia. Now, you will appreciate that blood pressure, it has been shown, and it was level A evidence that, and class 1, that it's dose response. So the A and C are all types of dementia, B and D are Alzheimer's disease. And the reason I'm showing you this is because of something unique. So of course, the more the systolic blood pressure would be there, as shown in A and B, the more likely an individual will develop dementia, and the more diastolic blood pressure will be there, the more likely they will have dementia, as in C. However, in D, there was a U-shaped response between the diastolic blood pressure and the development of Alzheimer's disease. And in fact, it was shown that between 90 and 100, diastolic, it is more of protective. And this is why the new idea is not to lower the blood pressure significantly. The previous idea used to be lower the blood pressure significantly so that the patients will not develop dementia. However, that's not true because there is not enough perfusion to the brain. So that's why we have to lower the blood pressure, but to a certain limit. Next, please. So this is a very important trial. We just came in July this year, and this was a meta-analysis for all types of dementia involved with hearing loss. And when I talk about hearing loss, it's not only the hearing loss in older patients. I'm talking about hearing loss in midlife and even early life. And it has shown that the hearing loss is independently associated with dementia. And one of our dear friends, Amanda, is working heavily on this. And this is a significantly amazing thing to look at and to do a research on, because hearing loss, the trials are not enough that if you fix the hearing, how likely will you stop dementia? Of course, it makes sense that you will, but how much will it be? She's working heavily on this, and I wish her all the best. So this is very important, and this just came out 2 months ago. Next slide, please. Now, the last few slides, I want to emphasize on something: education. So we know for the last 3 decades that the Shanghai study was the first study, which came in 1990. It showed that individuals who have more than 6 years of education, the likelihood, the prevalence of dementia is much lower than the ones who don't have it. However, if you look at the latest trial, which came out just last month, it is from the sub-Saharan Africa. They looked into the modifiable risk factors. And unfortunately, the most prominent modifiable risk factor was low formal education. And this is associated with incident dementia. This is why education is extremely important. And we have level 1 evidence for it, as is for hearing loss. These are the big things which came out this year. Next, please. So this is quite important as well. Last year, it was shown that sedentary behavior, well, unfortunately, COVID had a toll on us, and Prof. Jacova will be discussing that. So it showed that sedentary behavior was independently associated with increased risk of dementia. Yes, we enjoyed unfortunately, it was a lot of pain being in COVID. Many of us enjoyed Netflix and being couch potatoes, but it has taken a negative toll on us. And as you will appreciate that most of the trials have shown, and in fact, when you put all the trials together, that there is a significant burden from having sedentary life. Next, please. Now, Mediterranean diet. When we talk about Mediterranean diet, it's quite famous. it had shown previously that it decreases the free radicals and it improves longevity. So it was studied extensively in mild cognitive impairment. This is the phase before dementia, as well as in dementia. And it was shown as a level B evidence, like strong evidence, but not strong enough as level A, like, for instance, blood pressure control, hearing loss, and education. And prevention of stroke, but still it has benefit. It is associated with improvement in cognition, and this has been going on for several years. And in fact, next slide, please. I believe this is my last slide. So one of the trials, an important trial which came in JAMA, this was more than a decade ago, it combined the physical activity and Mediterranean diet with Alzheimer's disease. So there were 3 groups where high physical activity was there, which means more than 4 hours of exercise per week, or low physical activity, which means less than 1 hour. And if you look at this, the people who had high physical activity and high dietary stroke, down means declining, having more Alzheimer's over these years, over 10 years of period. So individuals who had high physical activity and high score in Mediterranean diet, they were less likely to develop Alzheimer's disease. I believe this is my last slide. Thank you very much for listening to me. I'm really grateful and gracious. Let's go for Prof. Jacova. She will enlighten us about the benefits of early diagnosis as well as about COVID. I believe you're tackling COVID today, Claudia. COVID and cognition, right? Thank you very much.
Yes, I hope everybody is hearing me okay. I'm calling in from the west coast of the United States. It's the morning and it's a very, very gloomy day. There's a storm happening. So I sure hope I'm going to be able to continue. Let's talk about
You're doing great. We can hear you. We can hear you very well. Thank you.
Let's talk about the benefits and challenges of an early diagnosis, and with a particular emphasis on the importance of differential diagnosis. Next slide, please. The first question we need to ask ourselves is, do people actually want to know? And a recent survey, it's called The Value of Knowing, shows us that indeed people do want to know. So this was a survey done in 5 EU countries and the US, and 85% of respondents said that they would want to be told they had Alzheimer's or another dementia if they experienced symptoms. This percentage was even higher when it was a family member that had symptoms. But if you consider the graph on the right, this was a question about if a test became available that shows you will in the future develop Alzheimer's or a related dementia, would you do this test? Well, the answers were much more split. That is, a third would about said, yes, I'm likely to get the test. A third said somewhat likely. And then another third that not at all said not too likely or not at all likely. So that really the clear data point here is that people want to know if indeed they do notice that they have symptoms. Next slide. Early diagnosis has been emphasized in many global dementia strategic plans. Next slide, please. Foremost, the World Health Organization that identifies early diagnosis as a primary goal in dementia care. And this is with a specific goal of promoting optimal management of the disease and providing the needed support. This is a recommendation that's evident in many national dementia strategic plans, like, for example, the UK has put forth in several iterations. Next slide. We need to ask ourselves, what do we actually mean by early diagnosis? And we can, so we can't anchor that to the biology of the disease. If you look at the arrow to the left, that is the neuropathology of the disease. And we know that it doesn't begin just before symptom onset, but years before, or even decades before. So people who harbor the disease for a very long time will have no impairment, and any kind of diagnosis would only be possible through biomarkers, for example, brain scanning or cerebrospinal fluid analysis. At some point, as neuropathology accumulates, symptoms become evident, and these are mild symptoms at the beginning. They are very difficult to differentiate from, normal aging. We could refer to these as early MCI, and still here, the consensus is that we really do need biomarkers to make a diagnosis. But as the symptoms become a little more evident, so mild, we refer to this as the late MCI stage, the disease is diagnosable. There are some risks, I will point them out later, but this is the window in which a diagnosis should occur. And this is earlier than what was done in the past, where the disease was diagnosed in the early, mid, or even late stage of the disease. And the problem with that timing, of course, is that neuropathology takes a big toll on the brain, and such late diagnosis, in fact, misses important opportunities for prevention and for treatment. Next slide, please. So I want to just talk a little bit about MCI. What is it? It's been a lot of studies, a lot of discussions, a lot of different diagnostic criteria put forth. MCI is an early symptomatic stage of the neurodegenerative dementias. It's a prodrome. Of course, we don't develop dementia overnight. It is preceded by a symptomatic stage that is different from normal aging. I think my graph hasn't entirely come through, but that's okay. So basically, a person destined to develop dementia begins to diverge in their function from normal aging and declines. And at that stage, in fact, a diagnosis can be made more firmly so as symptoms become more evident. In former times, such a diagnosis was not possible. It was only possible to diagnose when dementia was actually already evident, as Dr. Qadi explained, in terms of the impairment of everyday activity. Next slide, please. If we ask ourselves, what are the benefits of early diagnosis? Is this really a good thing to do? The benefits are actually pretty clear. There's been some research on them, and the most firmly established benefits are in terms of psychological benefits. Several studies have demonstrated that when people receive a diagnosis, there's actually a reduction in anxiety symptoms after diagnosis. It seems that there is no effect on depressive symptoms, and there is many people that receive a diagnosis speak of a reduction in uncertainty or an experience of relief despite the diagnosis itself. Another type of benefit that's widely recognized is a medical type of benefit, where if you receive a diagnosis, treatments of coexisting illnesses that impact cognitive function can actually be initiated. A better type of medication management suited to your needs can be started. You can start engaging in secondary prevention, which really means you can, change your lifestyle and receive treatments in order to delay the progression of the disease. In addition, when you have an early diagnosis, you avoid going from doctor to doctor in order to have clarification of what is going on with you. Additional benefits that are largely agreed upon are that people who receive an early diagnosis can actually access support systems early on in the disease and build resilience for the future challenging years of dementia. They can plan the future care while the patient is still capable, and patients themselves can consider participating in disease-modifying therapeutic trials, which is some patients really want to do that and don't care if there are side effects. They just want to give it a try. Next slide, please. There are other benefits that we need to consider. There's a large study on US Medicare recipients that showed that when you're diagnosed and you're immediately treated with approved medication, and that includes the cholinesterase inhibitors, the outcomes for you are better than if treatment is delayed or if you receive no treatment. So the comparison here is between patients immediately treated after diagnosis and those either untreated or treated after a delay. And you can see this, I'll get to the graph in a moment. There was better survival among the treated patients. Mortality rate was 10 versus 19 per 100 persons per year. There was a lower rate of nursing home placements, about 20% lower, and there was lower utilization of a bunch of services, inpatient, skilled nursing facility, and hospice. And this is, in fact, exactly demonstrated on the left, where the expenditures related to various services are plotted for treated and untreated, and you can see that the treated fare much better than the untreated patients. Next slide is a question about, can healthcare systems themselves save costs by diagnosing people early? And that indeed is also an answer in the affirmative. So several studies have looked at the question, can costs associated with early diagnosis, and these are real costs, can they be offset by later savings? A British study showed that an early diagnosis and intervention model was estimated to save about 220 million pounds per year, and that is in 2009 pounds, due to delayed institutionalization and better quality of life. Another study implemented what's known as Monte Carlo cost-benefit analysis. That's really simulations on the computer. And it showed that there are really large potentials for social and economic savings associated with early diagnosis and intervention. And in fact, the best results were for combined treatment of the patient and caregiver support intervention. There is one area that has not received any attention yet, is very important. Informal caregiver costs really shoulder the greatest burden in terms of dementia care costs, yet there has not been really any research on whether an early diagnosis might actually be beneficial to reduce informal caregiver costs. Next slide. One advantage or benefit of early diagnosis that's not often emphasized, but is incredibly important, is that there are opportunities for better differential diagnosis. First, consider the graph on the right. So it depicts all of the neurodegenerative dementias that Dr. Qadi showed in the pie chart: Alzheimer's, vascular dementia, I can't see this, frontotemporal dementia, primary progressive aphasia, and dementia with Lewy bodies. At the bottom, you see the early stages, and at the top, the later stages, the dementia stages of these diseases. And you can see that in the early stages, these diseases are actually very different from each other. But as the diseases progress, they become more and more similar, such that a differential diagnosis is easier at an earlier stage. Why is that important? For many reasons, foremost actually that the prognosis for these dementias is actually quite different. They have different courses and also different survival implications. They have different genetic risk implications. They have different needs for skilled care, and finally, different medication management considerations. For example, it is well known that dementia with Lewy bodies has sensitivity to a certain type of drugs, antipsychotic drugs, that need to be avoided with these patients. Next slide, please. So how are we actually doing in terms of diagnosis? The fact is we're not doing that well. A recent study that was actually published in 2017 estimated that worldwide, next slide, about 68% of cases were not detected. This rate is lower in the UK, in the EU, and in North America, where the range is about 43 to 60%. That's still very high, though. And it is much higher in some of the Asian countries, up to 90%. Undetected or missed cases are more common among younger groups, where dementia is less common, that is, people younger than 70, where the rate was 75%, and pretty concerningly, actually, in primary care settings, 68%. And we need to think that primary care is really the first point of contact for older patients that might be concerned about their memory and cognition. And in fact, from a provider perspective, GPs or primary care providers are charged with recognizing, detecting, and potentially diagnosing dementias. So this is an important area of work, in fact, actually. On the right, I just report some of the barriers that have been found in past studies. Barriers for the patient, definitely fear of stigma, I'll come back to that. Concern about the practical consequences. Cognitive symptoms are often not a priority in an older person that has other medical problems. And then there seems to be a tendency or a trust among older people that they'll rely on a physician to bring up the issues around cognitive function. If the physician doesn't, they won't either. There's also, for many older people, a problem of accessing the proper services. For the provider, the key barrier is actually lack of training and concerns about misdiagnosis, followed by perceptions that there are limited treatment options when you in fact do make a diagnosis. It's also a real reluctance to discuss cognitive symptoms with older people that maybe have been patients for a long time, is sort of an embarrassment. And then of course, there's limited time and resources. It's also system-related barriers, not surprisingly, insufficient community resources. Dementia is not a priority in public health, but it is becoming that, and a lack of specialists for consultation. Next slide, please. In that same vein, in my lab, we have always been very interested in the, what goes through people's minds when they seek a diagnosis. And this is a slide, next slide. Okay, this is a slide that, shows us, encourages us to think about the risks as well of an early diagnosis. There is a real risk of misdiagnosis. It has been estimated to be a whopping 12 to 23%. And of course, the earlier the diagnosis, the more likely that it is a misdiagnosis, unless it is, a diagnosis rendered with a lot of based on a lot of information, and by an experienced clinician. Other risks have to do more with the situation of the patient. There's a possibility of stigma, impact on autonomy, loss of identity, and social isolation. These have all been reported to be real phenomena following a diagnosis of dementia. And finally, there's a very concerning increased risk of suicidal behavior. In my lab, we looked actually at what worries people as they seek an assessment of their cognition. And so you see the worry statements there. Some of the top worries were, that people feared they would be no longer taken seriously, they would become depressed, they would become anxious, they would lose their driver's license and other privileges, they would be put in a nursing home. These are important worries. They do need to be addressed when people, come into an assessment situation. These are not trivial things, and they might indeed prevent people from seeking the help that they need. Next slide, please. With regard to the risk of misdiagnosis, one more consideration regards MCI, where for many years we've known that people with MCI do have a substantial risk of progressing to dementia. Next slide. A substantial risk of progressing to dementia you see in the slide when we get it. Next slide. You see 4 studies, but these are just, these are among many studies showing people with MCI followed over multiple years. And so indeed, there's a large percentage that do progress to dementia. You can see the rate of dementia at the top and the number in parentheses, the number of Alzheimer's disease patients. But if you go and look at the other 2 outcomes, a lot of people with MCI, up to a half in these studies, remain stable, and some even improve back to normal. So while the MCI stage is a critical stage for early diagnosis, it is also one where these outcomes must be kept in mind. And so, MCI diagnosis has to be rendered with a lot of caution and potentially longitudinally just observing the person over time. I am now leaving the topic of early diagnosis. Next slide. And want to talk just a little bit about the impact of COVID-19 on dementia. Next slide. Okay. Next slide.
Sorry, Claudia, I think you're lagging a bit. The slide is already on. Yeah.
Oh, what am I going to do?
No, that's fine. You just have to wait for a few seconds. Go on.
Oh,
that's
sure.
fine.
Yes.
Thank you.
Yes. So this is a study that shows the impact of the COVID-19 restrictions as in lockdown on patients. It was studied and this was published in 2020. And you can see here the neuropsychiatric symptom frequencies in patients with dementia after or during that lockdown. And the most frequent symptoms were apathy, anxiety, and motor agitation, followed by sad mood, loss of appetite, and impaired sleep. This is indeed, there's a wonderful paper that looked at the impact of COVID-19's restrictions on patients and really refer to these as more than a double blow. That is, people that are affected by dementia and on top of that, by the pandemic. And so the paper, next slide, please. The paper emphasizes that there will likely be some considerable collateral damage due to the pandemic for people with dementia. Next slide. I'm probably lagging, so I'm still seeing the previous slide. There we go. Why that collateral damage? Well, due to many reasons, and these will be probably clarified better in future research, but consider that people with dementia received fewer services. They received lower quality of care, and there was an excessive burden on the caregiver. In addition, there were also lost opportunities. That is, trials had to be halted and people could no longer sign up for them. In addition to this, the paper that I'm referring to also made a wonderful case that, the pandemic itself was very confusing and disorienting to patients. You can see there a typical dialogue as was experienced by clinicians. Good morning, Mrs. P. How do you feel today? Well, thank you. Aren't you rather annoyed by the current situation, by the fact you can't go out? What situation? I don't understand. And after an explanation, I don't know, I let my husband deal with this. This is an enormous challenge for people with dementia. Fundamentally, dementia entails memory loss, which means you're not really oriented to the reality of today in an ongoing and clear fashion. And this is a very confusing thing. Some patients are known to have said, oh, I think there's a war going on outside. So think how unsettling this might be for you if, your memory were not working well enough. Next slide, please. So can we conclude, or can we do we have some evidence of the rate of decline of patients with dementia during the pandemic? Yes, we actually do. So there's a study that followed people with dementia over these 6 years from 2016 to 2020. And you can notice here that on the mini-mental state exam, there was about a 1 point loss over the years until 2019. From 2019 to 2020, so the emergence of the pandemic, there was a 3 point loss on average among patients. Now, these are early data, and we'll have to see whether these hold up or whether perhaps the reality is even worse than what's depicted here. Next slide, please. For caregivers, this has been a very, very tough time too. The impact has been enormous. Caregivers already are known to suffer from anxiety, stress, and depression. This was more so the case during the COVID-19 restrictions, and more severe with more days of isolation, worse for women than men, and worse for caregivers was lower than higher education. A study actually looked, next slide, sorry, I'm forgetting. Next slide. A study looked at the tweets made by people with dementia and their families, and looked at the themes that emerged from these tweets. Next slide. And what you see here is really concerning. It's themes of separation and loss, COVID confusion, despair, and abandonment. It's that confusion and disorientation I was talking about earlier, stress and exhaustion exacerbation, and then importantly also unpaid sacrifices by formal care providers. I now want to turn to another aspect of the pandemic. Next slide, please. And that is that COVID-19 itself might be a risk factor for cognitive decline. So we've got some very good reasons for believing this. Next slide. Next slide. We know the virus is a neurotropic virus. This means it invades the brain through neurosensory pathways and the vasculature. We know that neurological symptoms are common in moderately and severely ill COVID-19 patients. And, there are MRI brain scan abnormalities that have been typically found in COVID-19, infarcts, microhemorrhages, and white matter abnormalities. Next slide. It is known that what we refer to as long COVID, that is people that have been ill but continue to suffer from the impact of COVID and, talk about brain fog. This has been actually substantiated in a study where those that indeed had been ill with COVID show cognitive deficits in reasoning, problem solving, spatial planning, selective attention, and note that actually episodic memory was not examined. We don't exactly know how that would look like. And on the right, you can see here that these cognitive deficits were directly proportional to the disease severity that is minimal for people that, yes, had some symptoms, but no respiratory symptoms, a little larger for people that had respiratory symptoms and perhaps needed assistance at home, and then really quite large and substantial for people who were hospitalized and either were not put on a ventilator or, and these are the largest deficits, on a ventilator. Next slide, please. Finally, there's a paper that really rattled me. And next slide. Its title is The Nth Wave of COVID-19. Will it be Alzheimer's? So when you look carefully at this paper, it is just published now. We know that Alzheimer's disease is actually increasingly seen as an immunological disorder of the brain. And key players are ones that are part of the innate immunity system. I'm not going to comment on it because I actually don't know exactly what I mean. But the key players are these PAMPs, that is pathogen-associated molecular patterns that are known to trigger neurotoxic immunoinflammation that is in fact assumed to occur early in Alzheimer's disease, and then ensuing cytotoxic protein misfolding. You heard Dr. Qadi talk about amyloid beta and potentially tau, we don't know. And the more the proteins misfold and accumulate, the more inflammation there is, such that ultimately there is a vicious cycle of a cascading situation affecting the brain. So we don't know whether this is going to happen, but there is biological plausibility, and at the very least, we should be prepared for it. And this is my last slide. Thank you very much.
Thank you, Claudia. Phenomenal as usual. Get to learn a lot from you. Bushra, you're here with us.
Yes, thank you. Thank you so much, Professor Claudia and Dr. Najeeb Qadi. And I really apologize for all the imperfections of the network that we are having. And I'm going to hope to God that the rest of the presentation can go smoothly. So thank you again, both of you, for this amazing insight into the silent pandemic called dementia. The world is failing people with dementia, that's all I can say, and that really hurts all of us. So 6 years ago, governments agreed on a clear set of targets to improve dementia care, but targets alone are not enough. We need intensive action to ensure all people with dementia are able to live with support and the dignity that they deserve. So with that in mind, Cogni.Dx was born, to democratize access to early dementia diagnosis and care. So when approaching a patient with possible dementia, taking a careful history is paramount. And because why is that necessary is because clues to the nature and etiology of the disorder are often found following this careful consultation with the patient and the carer. So this is what Cogni.Dx's primary solution and innovation is. It is to uniquely digitize and accelerate the manual procedure of history taking by developing a digital screening application of higher mental function questions, as well as cognitive assessments that, based on the answers given, will instantly deduce the probable dementia diagnosis. So this significantly reduces the delays in diagnosis at the primary care level and cuts down on inappropriate referrals to memory clinics. Our tool requires no clinical judgment and can be administered promptly at home by the patient or their carer, and the report is directly sent to the GP for evaluation on the first patient visit, thereby reducing time lost and the effort. So using the power of machine learning and with enough longitudinal data available in the future, predictive analytics will be incorporated in our tool to allocate appropriate healthcare resources and streamline the dementia pathway. Now, the three main services Cogni.Dx will provide is, of course, the first one, which is Cogni.Dx, which is our main diagnostic tool. Then we have Cogni Health, which will provide expert information on lifestyle changes in the pre-dementia, or as everyone mentioned, the MCI stages, and that is to delay the onset of any disease. And finally, we have Cogni Maintain, which is a follow-up and maintenance of quality of life for dementia patients in every phase of their and their carers' journey. In the current dementia diagnosis pathway, GPs, as you all know, are given just 10 minutes to do a quick medical examination, a medical history, a cognitive assessment, a physical examination, and order further investigations like labs. And in the specialist pathway, this process usually takes 45 minutes to 1 hour. So essentially, GPs are given less than a quarter of the time to reach a diagnosis similar to that of a specialist. With the introduction of Cogni.Dx, we are taking the burden off the GP and the specialist's shoulders and conducting all the history at home in a self-administered way by the patient or their caregiver. Not only that, but a huge portion of the cognitive assessment will also be done at home, which makes Cogni.Dx the first hybrid tool to be doing both the history and the assessments on a detailed level at home. Cogni.Dx will then instantly give this preliminary diagnosis to the GP, which is based on the rapid results of the assessment. And this leaves the GP with their precious 10 minutes in which they will only review the patient's history from our app, conduct the remaining assessments indicated by our app, and then do a quick physical and order labs. The Cogni.Dx diagnosis will then be sent to the GP, from the GP to the memory clinic to perform scans and validate the diagnosis. In this way, referrals to memory clinics will be appropriate, they will be filtered, and this will save the specialist's time to do other appropriate assessments like scans and order further investigations to confirm the diagnosis. Now, just to make you walk through a quick 8-step procedure of how Cogni.Dx works, the patient or their carer, of course, is concerned about their or their loved one's cognition or change in behavior. They quickly approach their GP to seek help and take an appointment. Their GP directs them to fill out the history questions and do an interactive cognitive assessment on the Cogni.Dx portal. The patient fills out the form in less than 20 to 25 minutes in the comfort of their own home. Cogni.Dx algorithm then immediately calculates the subtype of dementia, including any pre-dementia or MCI conditions, and a detailed report is sent immediately to the GP. The patient arrives to their first GP appointment with a holistic plan outlined by the GP via the Cogni.Dx portal. Now, if the patient was diagnosed with MCI, they are immediately moved to the Cogni Health service to start lifestyle changes and to delay the onset of disease. And if a diagnosis of dementia is made, the patient is referred first to the memory clinic and later moved to the Cogni Maintain service to maintain their complete health in every phase of their journey. Now, dementia has significant social and economic implications, as you have already seen by the previous talks, in terms of direct medical and social care costs and the costs of informal care. So in 2020, the estimated global societal cost of dementia was $1.3 trillion. And these costs are expected to surpass $3 trillion by 2030, as both the number of people living with dementia and care costs increase, making dementia the world's most expensive chronic condition. To give you a quick understanding of a few financial cost-saving propositions that Cogni.Dx can have, and bearing in mind that this is only for the UK and only in the dementia module of Cogni.Dx. So as the number of GP visits is reduced to only one visit, this has a direct saving cost of £6.3 million per year for the NHS primary care services. And as a result, misdiagnosed referrals are eliminated, and the memory clinics have a saving of around £5 million per year. Earlier diagnosis reduces the need for acute inpatient admissions, thus having savings of at least £51 million per year. Patient waiting times are reduced by 66%. And finally, the memory clinic capacity to see finally genuine patients increases by 39%. So dementia is a global pandemic, and hence, as you can imagine, the market opportunity of Cogni.Dx is vast, starting from UK, where 210,000 new cases of dementia are per year, and all the way to global scales that reach 10 million new cases per year. Now, the accuracy of a diagnosis is very essential in medical care. Although we can't draw any definitive conclusions based on our sample size of 300 patients, we have achieved much so far. So starting with the completion of our first clinical pilot with 97% accuracy in diagnosis rates using the history module alone, and going on to our second pilot with the introduction of machine learning earlier this year and achieving similar accuracy rates. And now we are starting our third pilot in the US with the development of our new hybrid tool. So 2 years ago, we participated in Zinc VC's Mission 3 program. This is a prestigious UK startup accelerator program, and we were chosen from 50 participants as one of the top 12 startups with the biggest potential. And we've had the full backup and endorsement of Zinc ever since. So our vision is to be the indispensable neurointelligent early stage diagnostic and long-term care solution trusted by all GPs, specialists, patients, and their families. And eventually, of course, to have a low-cost, highly effective, and predictive approach that democratizes access to fast dementia diagnosis. And before I end, a huge shout out to and gratitude to Zinc VC Venture Builders and all the Mission 3 portfolio companies that, along with Cogni.Dx, were born together under Zinc's umbrella. Thank you to each one of them for their endless support and encouragement. And in the end, we at Cogni.Dx are striving to make a little impact to help raise awareness towards this dreaded disease and provide our own solution that could help millions manage and live in dignity. I really hope this webinar shed a little light on this important subject. And if you have any further questions, you can contact us through the links that are provided in front of you. Thank you very much for taking the time out to join us today. It really means a lot. And we will now open the stage for all your questions. Thank you so much.
Thank you very much. Claudia, I believe you have 2 questions are there for you. Thank you everyone for coming. Can you see the questions? You are mute, I think, Claudia.
Okay, so I have, I don't know if this is the first, but there is.
How does dementia impact life expectancy in different age groups and genders? And then the other one, please.
Yeah. So that is a very good question. And I don't know that we actually have the answer to that. So first of all, I need to say that life expectancy is different for different dementias. So I would say we know most about Alzheimer's disease. And we know that there is a greater risk for dementia among specific groups, that is older adults and women. I believe it has also been found, but maybe Dr. Qadi can correct me, that women do have longevity, which does not help them in this case. That is, they have a long life with dementia, which, if it isn't supported properly and quality of life ensured for them, is not a good thing. That is as much as I know. I also know that some very young onset dementias have a fairly rapid course. This is, however, not necessarily Alzheimer's disease, but frontotemporal dementia. And the older a person gets up to a point, and in some way, the more benign the course, although it is a steady decline. Dr. Qadi, Najeeb, do you have anything that you want to add? Maybe I've missed that.
Not really. As you mentioned, I mean, it's there are differences. Many people have studied why women tend to live longer and why do they have more dementia than men, and this, and they went into theories, you know, like initially was it the estrogen, and even there was a recent evidence came level 1, A2, that they should not be taking the estrogen, you know, replacement therapy as management for dementia. Now, The point is, dementia is not only the life expectancy. I mean, that is there, but it's the quality of life. This is where the emphasis is. Like, you know, individuals are reaching, octogenarians, nonagenarians, and now even beyond 100. And then how is the quality of life happening? And my issue was more, as mentioned, about the caregivers who are unpaid caregivers, or we call them the informal caregivers. How is that affecting them? So as previously the term elderly used to be used. Now it's not used. It's older patient, because really the life expectancy and everything is improving. I think dementia has a very negative impact. Genders, yes, but there are many trials which are contradicting, Claudia. I'm not, you go to one side that, okay, it's the ladies, and then you get the other side, no, it's not. And then, for instance, frontotemporal dementia and Lewy body dementia is more common in men compared to females. The only reason we say it's more females is because Alzheimer's disease is the most common and they have it. So,
yeah.
If I may add,
sorry?
No, I just wanted to add something. I mean, both of you can correct me, because what I read was that globally dementia has a disproportionate impact on women. So 65% of total deaths due to dementia were actually for women. And when they did the disability adjusted life years due to dementia, it was roughly 60% higher in women than men. So
this is exactly what Claudia was talking about. But the problem is that the new, there are some anecdotal new, things coming up, which says the impact, it is significant in ladies, but the impact is exponentially increasing in men because the longevity of men is increasing. Before, it used to be less for wars, whatever. It's increasing. So there are, it is there, but I believe it will change. And the impact of both genders, not only ladies. This is my 2 cents of experience regarding this. Claudia, the second question. How can a caregiver improve a patient's quality of life that could prolong the life expectancy? Wonderful.
It's actually a very nice and good question, because there is a lot that can actually be done in terms of secondary prevention. So let me premise this by saying dementia is rather forgotten. So, we sort of, not we directly, but, society sort of thinks, okay, now you're diagnosed. We know, you're only going to get worse. And we forget about you. But really, that is not warranted at all. While I don't think you can, stop the disease from progressing, you can make it better from a quality viewpoint, but you can also engage. It is really never too late. You can engage in activities that keep a person engaged and potentially have also benefits for their, their brain. And those are all the good things that Najeeb mentioned, that is exercise, meaningful activities. There's a whole research effort on how do you engage a person with dementia in something that means something to them. How do you engage them in social activities? These are not things that, these are not activities as usual or business as usual. You're gonna have to, as a caregiver, try. However, I do know that, caregivers can get a lot of support from support groups, from Alzheimer's organizations in terms of more concrete ideas or sign-ups, for workshops, or just simply networks that support each other. I would never want to give up on a person with dementia. I really think that there's a lot of work left, and I think that a lot of funding should go into research to improve quality of life in dementia as well, and that's not the case right now. I hope this has answered your question.
Claudia, to mention even the caregiver's quality of life. When we talk about, we are emphasizing more on the patient, but what about the caregiver who like changes drastically his or her life because the loved one has dementia. So I agree with you. A lot of networking is needed, a lot of research is needed because the impact is quite heavy and negative.
And we know this. Caregivers cannot do a good job if they themselves are overwhelmed, and they usually
True.
are. And so the recommendation that's easily said and not so easily done is that caregivers really have to take care of themselves. And that too would occur with appropriate support services. It's essential that this happen for caregivers. Right. So they need to pay attention to themselves as well.
Another question, Claudia, is from Dr. Subhani. Dr. Shazi Subhani, she's one of the leaders in our genomic project for the whole country and especially in our institution. The question is, will you include genetics in diagnosis module?
That's a really good question. So the short answer is yes. Different dementias have different proportions of familiar cases. So some dementias have a pretty large proportion of autosomal dominant patterns. Right. Frontotemporal dementia is such, whereas for Alzheimer's disease, it's really a smaller proportion that are clearly familial cases. That would increase the confidence in the diagnosis enormously. But what you are likely talking about are instead risk genes, susceptibility genes. And they, I think, are certainly not yet used in clinical settings. Even the well-known ApoE gene, certain alleles an allele that definitely increases risk for Alzheimer's disease. This is, I don't think, done at a clinical level. Najeeb, correct me if I'm wrong, but I don't think
true. Very true. The problem is, Claudia, it's not like that Huntington's gene, like the penetrance will be 100% and the person will develop it. There are many individuals with even ApoE44 who live their normal life. So especially in the West, to have this gene diagnosed, insurance companies, a lot of impact will be like, insurance companies don't want to insure you because you probably have something, you might have a disease. So ethically, it's not possible easily. I do believe where you would use it more is if it's an early onset dementia or there is a strong family history, then you would like to, if an individual has come in the mild cognitive impairment stage or even before that, you would do the gene and you would do then the PET scan or the CSF study, and then you will say, okay, there is significant likelihood, and go for all the modifiable risk factor, algorithm, and try to prevent dementia as much as possible. There is
the problem with Alzheimer's in particular, actually, is that genetic factors are difficult to identify. That is, there are genome-wide studies where you can see a lot of tiny blips associated with the presence of certain alleles in certain genes. Problem is that this is not for everybody. That is now the belief is there are a lot of genes involved and they don't carry the same weight in different people. And that is not an easy situation.
And the load itself, it's different. Even the ApoE44 load is different. There is a phenomenal question by Mr. Hussain Ali or Dr. Ali. Bushra, I think it's something you and Claudia need to tackle. He says, as I understand, the machine learning algorithm requires the training sample, and the training sample can be from different backgrounds, gender, and other factors. How does a history test and machine learning take this into account, these physical constraints?
So
wow. I love the question. Bushra.
So what I can say is that go ahead. I mean, I can just say that we are currently developing this machine learning infrastructure to accelerate the diagnosis even more. So we first created the heuristic model, which was based on retrospective electronic patient histories that we acquired in pilots 1 and 2. And this was by putting weights on each and every history question. And then eventually, based on that, we'll be building a predictive model based on dementia risk factors and other noticeable trends from the data. So what happens is that you divide the historical data into both the training sample and the testing sample. And then we use the training sample to train the algorithm and test it on the testing sample. And of course, in the history, we are taking all these factors into account: the age, the gender, the ethnic background. So all of these things are taken into account. And with the different pilots that we are conducting in the different demographics around the world, this will be very interesting to see how the patients, for example, in Saudi Arabia are different from the ones in US, Canada, and the UK.
So, I mean, if you allow me, Bushra, I mean, that is very true what you mentioned, but something important here is that it's a learning process by itself. Even if we feel that we have all the questions, we have everything, machine learning is going to help us continuously to, either to fulfill the prophecy or to refute it. Like certain questions, maybe we feel that these are perfect questions and this is the perfect way to go. And with time, it will show the emphasis on these questions is more in a certain, place. Like, for instance, in states, these questions make more sense. In other areas, different questions make sense. And this is where the different gender comes into picture, ethnic backgrounds, other things come into picture. So it's a process which will continue to improve. And this is the way for the big data, how it will help us. And later on, we can go into process mining. And this will be very beneficial. So this is my what I think about it. What do you think, Claudia?
Oh, I don't. I am basically a very data-driven person, and I completely agree that the data you derive from a certain, data set or collected on a certain group of people will always reflect their characteristics rather than be a generalizable algorithm at the outset. So I would say that there will have to be several attempts, because there could be, we know this, there could be specific factors that could be very important in certain groups, but not in others. And so there will be a lot of studies, needed. I would even argue that data gained in the UK might be a little bit different from data gained in the North American countries, certainly in the South American countries, if we ever thought of going there. So this is, going to be an ongoing effort, I think.
I agree.
Thank you so much,
Bushra, the floor is yours.
Yeah, I'm not sure if there are any more questions. And
I actually have a question in my box. It's an absolutely phenomenal question. That is, this is the question: are there studies on the rate of progression to full-blown dementia when biomarkers such as amyloid in the brain are used for early diagnosis for asymptomatic people? This is
wow.
It's at the heart.
Wow.
Yes.
Who asked this question? That is someone really good in this field.
Patricia Kinzer. This is a great question, and it is one that is useful to, is very important, because basically amyloid is also present in older people that don't seem to progress to Alzheimer's disease, such that if we just looked at amyloid in the brain, we should not, in fact, make a diagnosis of future Alzheimer's disease. It is not certainly, this is not warranted. So when I talk about biomarkers, I would never only talk about amyloid, because amyloid is very sensitive, but it is not very specific. And so it might, in fact, for reasons that are very intriguing, might in fact be present in a lot of older people who will never get Alzheimer's disease. And maybe there are some protective things that we don't understand. So we do need to look not only at amyloid, but also, at tau. And I think it might actually be in the future important also to look at inflammatory markers as a way of increasing the accuracy of diagnosis. I hope this answers your super excellent question.
I would just add to that, Claudia, if you remember, I mean, this was the criteria you and Dubois came out with. That's why you kept it as a research criteria rather than a clinical criteria, because I mean, it's the PET scan, it's the CSF analysis. Some look at A beta 42, tau, and phospho-tau. And the latest papers are coming that phospho-tau might be more specific, especially phospho-tau 181. So, but the problem is again that many normal individuals have abundance of amyloid, especially elderly, and they never develop Alzheimer's disease. In fact, there was a recent paper which came last year. It talked about autopsy, that on autopsy, individuals were found to have moderate type of Alzheimer's disease, the burden of amyloid, and they never had any cognitive decline. So it's very challenging. And on the other hand, you remember the vaccine, which was then stopped, in the French, the 9 individuals who got the vaccine, and some of them, they found that in the autopsy, there was no more amyloid. It was taken out, or it was very little, but they continued to progress with their disease. So as you said, inflammatory markers, a lot of issues, and inflammation, COVID has affected the Alzheimer's patient because of the autoimmune and inflammatory process rather than amyloid and something else. Even though now you showed us the nth wave, I haven't seen it. It's amazing. Like even amyloid can get affected. Like we'll have to see.
And Dr. Qadi, does vitamin B have any effect on dementia?
Okay, wow. Okay, so I had initially put it and then I removed it. I said no one will ask, and then someone asks. This is what happens when you you rethink about it. So okay, so vitamin B is a tricky thing, and Prof. Jacova and I were just discussing a couple of days ago about this, because we were the point is that previously there was a big trial that came in JAMA 2009 for a period of 7 years. They looked into B, and they found if a person does not have a significant deficiency in like B1 because of chronic alcoholism, or B12, vitamin B has no effect on delaying decline of cognition. However, recently 2 different meta-analyses have come into picture, and this is for elderly individuals who are cognitively normal. One of them feels, who included all the patients and the elderly, all of them, they found that there was no benefit. However, the trial which discussed only the cognitively normal individuals who have, who were taking vitamin B complex, they found that the likelihood of them developing later on, MCI or dementia would be less. But we have to bear in mind, this is more of observational studies. And you remember, Claudia, you were just telling me about it. Like, if you remember the plot, like you were saying, there were a lot of, what was the exact term you used? Because it was very important. From the past, there were some, like in fact, the confidence interval, it was on both sides of.
Oh, yes. So wide confidence intervals, or the effect falling on both sides of the baseline.
On both sides, yes. So then it's tricky. I mean, take vitamin B if you want to take it. I tell this to my so individuals. They say we want to take it, fine, but the evidence is not strong about it. Anything else? I believe no more questions. Perfect. Yeah, I'm amazed how many, all of them are still here.
I know, and thank you so much, everyone, for being here. And if you have any more questions. Okay, so Mr. Hussain is saying, thanks for your detailed answer. I worked on a similar project and found it challenging to bring in demographics in the ML prediction, and I think it will be exciting to test it on people from wide background demographics. Has the data been published in any journal for us researchers to review? No, not yet. We are still very early. Yeah, we are still very early, but soon, I think towards the middle of next year, we should be coming out with some kind of results with our pilot in US, hopefully. Thank you for joining us, everyone. I'm not sure if there are any more questions. If there are no more questions, I think we will end our webinar here. Hang on, there's one more. I didn't get the point on vaccine. I didn't get the point on vaccine being stopped because of a study. Is this the COVID vaccine?
Oh, okay. I'm so sorry. Okay, no. This was a study done many years ago, and it was the amyloid for the amyloid beta. Like they would give you the vaccine, and they found that there was meningoencephalitis of 8 or 9 patients, and they were all in France, if I'm not wrong, Claudia. Correct me if I'm wrong. And then they had to terminate the vaccine study. But these individuals, they followed them up, and then they did the autopsy for their brain, and they found that some of them really had the amyloid. Some had not decreased, some had decreased, and some it had really vanished from the when you talk about the hippocampal region and CA4 region, and then but they continued to decline. So that's a different type of vaccine. Anything in the horizon, Claudia? Any new vaccine coming up?
Not that I know. And yeah, just be really, really clear. This is not about the COVID vaccines. They're fine. This is really about the vaccinations for amyloid, so monoclonal antibody treatments. The thing about that, as is also, reflected in my answer regarding the long-term outcomes of people with amyloid in the brain, amyloid may not be the most important target to hit. This is the reality. We may be able to remove it from the brain, and then, people still go on and get worse. So, so this is the reality right now.
True, very true. And the question Mr. Ali is asking, how can we prevent dementia in its early stages? Well, this is the point. Like, once dementia happens, there are studies that show that even if you continue exercise, there were a meta-analysis done on using musical instruments for people who are used to it, that it decreases the decline. But the major aspect is how to prevent dementia from happening. And this is why the early diagnosis or even tackling MCI is important, because as I mentioned, and Dr. Jacova as well, if you make sure it's a process across lifespan. If you make sure the education, the blood pressure point, if there is a hearing impairment issue, make sure stroke prevention is there, exercise, Mediterranean diet. So it's a holistic approach, which we call it a multimodal effect. And that could be prevented to some extent. The only thing which from the many, there are trials, but of course, no one will do a randomized control trial that curcumin, berries, and of course unsaturated, you were very strong on the berries and the blueberries part. I remember, Prof. Jacova, you believe it really has a good antioxidant.
It's blueberries have been felt to be really the best agent for prevention, but there are no data, and so this is just a belief, and I really don't like to go with beliefs. But blueberries are delicious. Why don't you just eat them? And
I had my doubts, because you have a lot of shops of blueberries selling blueberries. I have doubts about this blueberry part being the ultimate.
Garden. I grow
you
them.
do? Okay, wonderful.
But I'm not.
I have started taking berries.
Oh, okay.
I have started taking, and there is also, they use now it's used a lot, the polyunsaturated, what do we call it? Because there was a lot of emphasis. Coconut oil did not help. However, there were some trials. 3 were a failure and 2 were helpful for the type 3 of taking. It's just coming out of my brain. We usually recommend it. Well, it slipped my mind. Let's go for another question till I remember that. We received a question from Twitter. Most common sedatives such as benzodiazepines cause delirium, which are usually given to COVID patients. Can COVID delirium bring on dementia? Wow. Okay, so that's a very good question. So benzodiazepines not only cause delirium, it can lead to dementia per se. Long-term use of benzodiazepines can affect the frontal lobe and can cause damage. And I have seen personally patients who were addicted. So it's addiction. So, however, when you're talking about COVID, you give benzodiazepines, it's a very for a very small period of time, and it's for a certain reason, and that should not cause, sedatives should not cause it. Delirium per se, does it lead to dementia? Well, if it's a chronic delirium and there is already a pathology, you call it delirium on top of cognitive decline, it can lead to something, but not something related to COVID. Another question from Twitter: Have there been any studies on the impact of dementia from the COVID vaccines, Claudia?
I don't think so. I mean, I honestly don't know about the literature, and I don't know that they have actually looked at this. So this is something that we'll probably learn about in the future, but it is a very good question, and I have not got an answer regarding this. I would actually argue somewhat the opposite. I would say the more you can prevent severe COVID disease, the more likely you're going to prevent dementia. However, so get vaccinated, but of course, there is a legitimacy to the question asked by Faria as well. So it's you know, we'll have to do the proper studies on that.
Right. So I just remembered I was talking about omega-3. You remember, like, omega-3 has been,
Yes.
I don't know why I couldn't remember it. So omega-3 has had some benefit, but it couldn't be proven. The problem is with medications, you cannot really, or I mean, with food, you cannot really do blinded studies. It's not that easy, and people won't really pay that. But healthy diet definitely helps. Now, for this point, which I really believe, Claudia, you know, the mRNA with the new concept of the vaccines, which is coming into picture. In fact, they are saying that now they are trying to target cancers with it. They are trying to target other diseases with this mRNA therapy. So maybe this is the therapy of future. So maybe it should be more beneficial rather than being more, causing an impact.
I think so, but it is ultimately a question that, yeah, we have to have the data for that. And not to my knowledge, it's possible that they're being collected. I don't know about that.
Right. Okay.
Okay,
Bushra, back to you.
I think that's the end of the questions, and I'm very weary of the time. And I really, really want to thank everyone for sticking around for so long. And thank you both for such a fascinating discussion, such amazing questions, which gave fuel to more discussion. And I'm really, really thankful that everyone has joined us in this venture, to raise awareness about this dreaded disease. And hopefully whatever impact that we can make is going to be, just a little ripple in that big ocean that is called dementia, which is becoming a forgotten pandemic. Thank you all so much. And thank you for joining us. And if you need to contact any of us, please, here are the links that Dania has just written in the chat. You can contact us from any of that. You can drop us an email. And it was lovely seeing all of you. Thank you. Thank you, Dr. Jacova and Dr. Najeeb.
Thank you.
Bye-bye, everybody.
Thank you very much.
Thank you. Bye, everyone. Thanks.
Thank you.